Management of Epithelial Precancerous Conditions and Lesions in the Stomach, MAPS 2, European Society of Gastrointestinal Endoscopy, ESGE, European Helicobacter and Microbiota Study Group, EHMSG, European Society of Pathology, ESP, and Sociedade Portuguesa de Endoscopia Digestiva, SPED, Guideline Update 2019. Introduction. Gastric cancer is still a major world problem, ranking 5th for incidence and 3rd for cancer-related mortality worldwide in the latest published global cancer statistics. Even though early recognition and treatment is possible, most cases are diagnosed at a late stage, and thus most patients with a diagnosis of gastric cancer die of the disease. Screening and surveillance of people at risk may decrease gastric cancer mortality by allowing early detection and treatment, often by endoscopy instead of more invasive surgery, and have therefore been recommended. In 2012, the European Society of Gastrointestinal Endoscopy, ESGE, the Sociedade Portuguesa de Endoscopia Digestiva, SPED, the European Helicobacter and Microbiota Study Group, EHMSG, and the European Society of Pathology, ESP, produced the first international guideline on the management of precancerous conditions and lesions in the stomach, MAPS. Its recommendations were then presented in various countries and were adapted and translated in some. Moreover, the MAPS guideline was incorporated into ESGE guidelines on quality parameters for upper gastrointestinal GI endoscopy. This document aims to update the first MAPS guideline, referred to here as MAPS 1, and to summarize current evidence on the management of patients with precancerous conditions and lesions, focusing on the evidence published after 2010. Main recommendations. Patients with chronic atrophic gastritis or intestinal metaplasia, IM, are at risk for gastric adenocarcinoma. This underscores the importance of diagnosis and risk stratification for these patients. High-definition endoscopy with chromoendoscopy, CE, is better than high-definition white light endoscopy alone for this purpose. Virtual CE can guide biopsies for staging atrophic and metaplastic changes and can target neoplastic lesions. Biopsies should be taken from at least 2 topographic sites, antrum and corpus, and labeled in 2 separate vials. For patients with mild to moderate atrophy restricted to the antrum, there is no evidence to recommend surveillance. In patients with IM at a single location, but with a family history of gastric cancer, incomplete IM, or persistent Helicobacter pylori gastritis, endoscopic surveillance with CE and guided biopsies may be considered in 3 years. Patients with advanced stages of atrophic gastritis should be followed up with a high-quality endoscopy every 3 years. In patients with dysplasia, in the absence of an endoscopically defined lesion, immediate high-quality endoscopic reassessment with CE is recommended. Patients with an endoscopically visible lesion harboring low or high-grade dysplasia or carcinoma should undergo staging and treatment. H. pylori eradication heals non-atrophic chronic gastritis, may lead to regression of atrophic gastritis, and reduces the risk of gastric cancer in patients with these conditions, and it is recommended. H. pylori eradication is also recommended for patients with neoplasia after endoscopic therapy. In intermediate to high-risk regions, identification and surveillance of patients with precancerous gastric conditions is cost-effective.